اللهم إني أسألك علما نافعا رزقا طيبا وعملا متقبلا شفاء من كل داء. Placenta previa. By definition, the placenta is implanted partially or completely over the lower uterine segment, over or adjacent to the internal os. It is called placenta previa. So, relationship with the internal os is important. In placenta previa, the placenta is implanted in the lower uterine segment such that is completely or partially covered the cervix or is close enough to the cervix to cause bleeding when the cervix is dilated or the lower uterine segment phases. Here you can see in this diagram, this picture is placenta previa. It is covering the os. And here is the cervix. And this is the presenting part. In 80% of the cases, it is found in multiparous women. The incidence is increased beyond the age of 35 with high birth order pregnancies and in multiple pregnancy. The incidence is approximately 4 to 5 per 1,000 pregnancies. Risk factors: multiparity, increased maternal age, higher altitude, history of previous scar in the uterus, and smoking. As far as the higher altitude is concerned, it is because of the oxygen saturation level. As we go higher, and the oxygen saturation, it is also affected. There are 4 types of placenta previa depending upon the degree of the extension of the placenta to the lower segment. Type 1, low-lying. Type 2, marginal. Type 3, incomplete or partial central. Type 4, central or total. Types, degrees of the placenta previa. If you see here in this picture, in this diagram, they have shown the cervix and it is the placenta. This is only in the margin. Then internal os and then it is the placenta relation. This is like, and you see only the part is only left and the rest is covered by the placenta. Type 3. Type 4, the whole, it covers the placenta. Whole of the os is covered by the placenta. For clinical purpose, the types are graded into mild degree, type 1 and type 2 interior, and major degree, type 2 posterior, 3 and 4. Type 1, it's also low-lying placenta. The major part of placenta is attached to the upper segment and only the lower margin encroaches onto the lower segment but not to the os. Here you can see in type 2, that is called marginal, the placenta reaches the margin of the internal os but does not cover it. This is the marginal, you can appreciate. It is not covering it. It reaches but not covering it. Incomplete or partial central. The placenta covers the internal os partially, covers the internal os when closed, but does not entirely do so when fully dilated. You can see in this picture here. Type 4, central or total. The placenta completely covers the internal os even after it is fully dilated. You see, even it is fully dilated, it is covering the whole. That is total placenta. Whole of the os is covered. Types, degrees of placenta previa. Again, you can appreciate in this. Mild degree, type 1 and type 2 interior. Major degree, type 2 posterior, 3 and 4. Clinical features, symptoms: vaginal bleeding, sudden in onset, painless. It is the painless bleeding which usually it is the common symptom in the case of placenta previa. Revealed bleeding, fresh blood, bright red or dark colored, unrelated to the activity. Patient is lying down on the bed or she just awoke and usually the patient see there is a bed wetting and she can feel the wetness of the sheet. But when you see focus, it is not the water, it's not the anything else, but only the red color blood. This is painless bleeding, which really that feels her alarming and to seek the doctor immediately. Here you can see in pictorial form the bleeding is, and placenta, you can see this is the cord attached to the fetus, and then placenta, bleeding is coming out, and it is directly from the fetus. Signs: general condition and anemia. They are proportionate to the visible blood loss. Abdominal examination: the size of the uterus. Uterus feels relaxed and soft. The head is floating in contrast to the period of gestation. Fetal heart sound is usually present. Vaginal inspection. Placenta is felt on the lower segment. Complications. Complication of the placenta previa. Number 1, maternal complications during pregnancy, during labor, puerperium, and then number 2 is the fetal complications. Maternal complication during pregnancy, antepartum hemorrhage, that is malpresentation, and premature labor. During labor, early rupture of the membranes, that is cord prolapse, slow dilatation of the cervix, intrapartum hemorrhage. Puerperium, postpartum hemorrhage, retained placenta, subinvolution. Fetal complication, low birth weight, asphyxia, intrauterine death. Diagnosis, that is placentography by the sonogram, that is ultrasound, color Doppler flow study, magnetic resonance, vaginal examination. Vaginal examination is not indicated in all the cases, especially in the case of placenta previa type 3 and 4. Management, prevention, immediate management, expectant management, active and nursing management. Prevention. To minimize the risk, the following guidelines are useful: adequate antenatal care, significance of warning hemorrhage, at home, put the patient on bed, abdominal examination, vaginal examination must not be done. Transfer to the hospital, admission to the hospital is important. Immediate attention. To ensure an adequate blood supply to a woman and fetus, place the woman immediately on the bed rest in a side-lying position. A large bore IV cannula is sited and infusion of normal saline, gentle abdominal palpation. Scheme of management. All APH patients are to be admitted. Journal and abdominal examination, clinical assessment of the blood loss, resuscitation if necessary, localization of placenta, expectant management, and then active interferences. In expectant management, the expectant treatment is carried up to 37 weeks. The aim is to continue pregnancy for fetal maturity without compromising the maternal health. Indications: no active bleeding, patient stable hemodynamically, fetal heart sounds are good, CTG reactive. Interventions: bed rest, periodic inspection of the vulval pads, supplementary hematinics if patient is anemic, use of tocolysis. Now this tocolysis is controversial. One school of thought is that tocolysis causes relaxation of the uterus and it causes further bleeding. So it is according to the situation we have to decide. Next is the RH immunoglobulin to all RH negative mother. It should be given. Indications: active management. Bleeding occurs at or after 37 weeks of pregnancy. Patient is in labor. Fetal heart sound absent. Gross fetal malformations. Dead fetus. In active management, vaginal delivery, and on the other hand we have the cesarean delivery is the option. Placental edge is within 2 cm from the internal os. In this case, no internal examination is performed and cesarean section is considered as the best choice. Placental edge is 2 to 3 cm away from the internal cervical os. Internal examination in OT, operation theatre, not in the labor room. ARM, artificial rupture of the membrane with or without oxytocin. On one side, satisfactory progress of the labor, that is vaginal delivery, of course, it is the outcome. And on the other side, if the bleeding continues and no labor initiation, then cesarean section is the solution. Nursing management. Nursing diagnosis, that is decreased cardiac output related to the blood loss as manifested by increase in heart rate. Interventions, monitor vital signs, provide adequate rest and reposition client. Encourage relaxation techniques, elevate hemoglobin of the client, patient, encourage use of relaxation techniques. Ineffective tissue perfusion related to decrease in hemoglobin in blood as manifested by dyspnea. Interventions, that is monitor vital signs, encourage quiet and restful environment, encourage use of relaxation techniques, provide supplemental oxygen to the client as prescribed by the physician. Deficient fluid volume related to the blood loss as manifested by the vital sign changes. Again, that is the monitor vital signs, monitor fetal heart rate, initiate IV fluids as ordered by the physician, and place the patient in the left lateral position. Fear related to the outcome of pregnancy as manifested by facial expression of the mother. Nursing interventions, assess fetal heart sounds, allow the mother to share her feelings, answer the mother's question honestly, include the mother in the planning of the care, plan for both the mother and the baby. And next is, thanks very much. I hope my lecture will help in your studies.